estrogen is so protective of breast tissue. It, number one, decreases the incidence of getting breast cancer in the first place. But if you're on estrogen replacement and you get breast cancer, your fatality incidence is incredibly reduced. The doctors have been told that hormones drive cancer. So there's this huge misconception, and women miss out. And the women who take hormone replacement get less cancers, less heart disease, less dementia, and they cost the country less. I believe that we are run by big pharma, and they want us to need bone meds and cognition meds and put us in the nursing homes. So we have this pharmaceutical industrial nursing home complex that is making money off of keeping us sick because women on hormones are less sick.
Hi, everyone. I'm extremely honored and excited to be talking with Dr. Lindsey Berkson today. Dr. Berkson is a researcher, best-selling author, a clinician, an educator, and a distinguished hormone scholar at an estrogen think tank in Tulane, where she spent 10 years. She has an incredible depth of understanding of hormones and how they impact our body, and she's written several books on the topic, among them Safe Hormones, Smart Women. She's someone that I have learned a tremendous amount from, and I'm extremely excited to have her on the podcast to have this important discussion about estrogen. Dr. Berkson, thank you for joining me on this episode, and welcome to the show.
Excited to be here. Thank you so much.
I wanted to start off with your personal story because, unlike other physicians, you have a unique vantage point where you can empathize with a patient because you're a patient yourself. And so I just wanted you to start off with your own story first about your own health journey and how that impacts how you see hormones and how you see patients.
Thank you so much. You know, it makes such a big difference when you've had the honor and the fickle finger of fate of sitting on both sides of the desk. Because it's one thing to deliver healthcare, and it's another thing to get a diagnosis of cancer or get multiple diagnoses of cancer.
Right.
So really the big deal is, I guess we should start with the fact that I just turned 75 2 weeks ago.
Wow.
And most people who are my age don't get to keep working out at the gym, kayaking. I'm leaving in a few days to travel to Detroit. I'm lecturing for 8.5 hours to a room full of 150 doctors. Most women my age can't even project, let alone speak for 8.5 hours to 150 doctors. One of the reasons I could do this is that I have been on bioidentical hormone replacement for almost 28 years. But the caveat is that 30 years ago, I was diagnosed with breast cancer. In fact, I've had multiple hormonally driven diseases. So in terms of looking at me in standard of care, I'm a high-risk patient. And most of my sisters of the heart, my tribal sisters who've also had breast cancer, they're denied hormones. They're told you can never be on hormones. So I feel like my journey in my career and also what I've experienced as a patient is so important to share, because so many women go through a horrific diagnosis, and then they might even not even have a horrific diagnosis. It might be that their aunt has factor V Leiden, a procoagulative genetic disease, and they're told you have high risk family. You can never be on hormones. And there's so much misconception about what is going on with hormones, who should be on them, who could take them, the safety of hormones. So I've learned a lot of this, not only from writing books and from being a distinguished hormone scholar at a think tank, but of also being a person who has suffered hormonally driven diseases. So a little bit in a shortened cliff notes of my experience, I'm one of the rare people who was living a really healthful life, doing everything right, but getting the wrong outcome. Most people live a typical life, then get ill, and then maybe turn on to healthy habits after that. I heard a lecture that you are what you eat when I was 17, 18. It made sense to me. I raised my own food. I had my own goats. My mother was state champion in tennis in Illinois, so I was working out all my life. I became a yoga teacher for many years, meditated, practiced forgiveness, and I just kept getting cancer. So I was doing everything right, but getting the wrong outcomes. And now fast forward, I had read an article that our planet was covered in a layer of pollutants that attack hormones. And I thought that this would be a great topic for a book. So I wrote one of the very first breakthrough books on endocrine disruptors. Endocrine disruptors are chemicals in air, food, and water, like microplastics that are now found in bottled water that's in plastic, which are now seen in sperm and egg and placenta. They're in all of us. They're in our gut, our feces. Microplastics are a very real phenomena. The problem is they make our hormones not work well. So I was writing a book on this very concept, and I got invited to be a scholar at an estrogen think tank, and I met Retha Newbold, who was one of the major researchers at Research Triangle Park at Duke, who had discovered that the man who ran the think tank, John McLaughlin, who is the world famous expert on estrogen, John and Retha were sharing with me that when they exposed rodents in the womb to a chemical called diethylstilbestrol, or DES, those rodents, the offspring of those rodents, ended up having many of the exact health problems that I had, the same cancers, the same health problems, etc. So I was always trying to figure out, why am I doing everything right but getting the wrong outcomes? Then I get to work at this think tank, and they told me that they were really researching endocrine disruption, and the model compound was something that had been given to pregnant women all around the world, but mostly in the United States. And this compound was given in prenatal vitamins. They added it to 365 different prenatal vitamins because they thought that this exciting new estrogen would make a normal pregnancy even better. And if a pregnant woman was spotting, they gave her injections of it. But then they discovered that that compound, the nickname for that compound is DES. They discovered that that compound gave the offspring infertility. That was the first thing that they saw. And I could not have kids, let alone also have cancer. So I thought, wow, I wonder if my mother was given this when she was pregnant with me. So I wrote away from my mother's birth records, which I got right before Michael Reese Hospital, where I was born, was torn down. It was an old, iconic institution in Chicago. I was able to get these microfiche records of my mom's birth, and she was given prenatal vitamins that had diethylstilbestrol, or DES, in it. She also spotted, and she was given multiple injections of DES during the first trimester when the fetus is more susceptible to endocrine disruption. So then I realized this is why I'm doing everything right, but getting wrong outcomes, because in utero, I had exposure to the most powerful endocrine disruptor ever invented. So then I started figuring out, well, how do we theorize that this causes cancer? And I was able to start turning that around. And that led me to a huge amount of research on hormones, which then led me to research that we have a misunderstanding of estrogen. So I decided that since I had lost so many organs from my journey of cancer, because I had multiple cancers. So I lost a kidney, I lost an adrenal gland, I lost a big part of my thyroid, I lost parathyroid. I mean, I had a total hysterectomy. I was walking around with much less organic matter inside of my body, and I was young. And I was really looking at accelerated aging. So I wanted to see if I could take hormones, because hormones would make up for the fact that I lost so many of my own hormone producing organs. And everybody told me, my oncologist told me never to go on hormones. All my colleagues, my functional medicine colleagues said, no one my age had ever been on hormones if you had breast cancer. So I decided to do incredible research, and I was shocked at what I discovered, and I decided to go on hormones myself. I felt that they were not only safe, they would most likely prevent me from having a recurrence. And if I did have a recurrence, they would most likely prevent me from dying from it. In other words, estrogen is so protective of breast tissue. It, number one, decreases the incidence of getting breast cancer in the first place. But if you're on estrogen replacement and you get breast cancer, your fatality incidence is incredibly reduced. So I have now been on hormone replacement for 28 years after having a diagnosis of breast cancer and then multiple diagnoses of cancer. And I've gone on a quest. I wrote the book, Save Hormones, Smart Women, which was the in-depth analysis of the Women's Health Initiative, because a lot of the data says we learned from the Women's Health Initiative that estrogen drives cancer and women should not be on it. Yeah. But if you really look at the literature, so why did we do the Women's Health Initiative? We're an aging nation. And they say by 2030, the majority of us will be over 65. So the United States was trying to figure out a way to not topple Medicare. So 40 prestigious institutions such as Harvard and Fred Hutchinson Research Cancer Institute, they got together and they looked at women every which way. And one of the very first studies they did was on hormones. Hormone replacement began in England in the mid-1950s, and it really picked up speed. And women did so well on it clinically that in Britain and then the United States started to do hormone replacement, although we did more synthetic forms of hormone replacement than England did. We started to give it to people after they had stints, after they had heart attacks, if they had congestive heart failure. They used it as an adjunctive care for adverse cardiovascular issues. If you had heart health issues, they gave women estrogen, and women seemed to do really great with it. They did not seem to have an increased incidence of breast cancer. So they said, let's run a randomized trial in this Women's Health Initiative, looking at how to keep women healthier longer and not topple Medicare. Let's run a trial on estrogen only, and then let's run a trial on the most common way that estrogen at that point in the 1960s and all the way up to the 2000s, estrogen was most commonly prescribed in the United States as a combo product. It was horse equine estrogen called conjugated equine estrogen, or Premarin, combined with a synthetic progestin, medroxyprogesterone acetate. And together they were called Prempro. Prempro was the bomb. Everybody was being put on Prempro. So they said, let's do an arm with just the estrogen, which was from a horse, and women swallowed it. And then let's do another section of the study, which is part of the study is called an arm, and we'll give those women Prempro. And they were going to put women on these hormones for 8 years and track them. And this is where we all got derailed. So the women on the Prempro arm, within a few years, started to look like they had more clots and adverse heart issues, but they also looked like they were having more breast cancer. So that arm, the Prempro, the combo arm, was stopped. Yeah. The estrogen-only arm was not stopped. It went on a few more years, and it was only because there was a slight increased risk of ischemic stroke and clotting, which we know you get if you swallow hormones and don't put them on topically or vaginally, because the way you get them in your body makes all the difference. It was stopped a few years later, but the estrogen-only arm was never found to have an increased incidence of breast cancer, ever. In fact, they did sequential reanalyses of the estrogen-only arm at 3 years, 5 years, 10 years, but they published the huge final reanalysis in 2019. They presented it at the San Antonio Breast Cancer Convention. Every year in San Antonio, here in Texas, they get together in December and they have a big breast cancer symposium. And they take a look at all the researchers get together, and there they had a reanalysis of the Women's Health Initiative. It was almost a 20-year reanalysis, and the same authors of the Women's Health Initiative, the very original authors, if they were still alive, they said, we have found that if women were on estrogen for an average of 5 years, they had a decreased incidence of breast cancer by 23%. That means your risk of getting breast cancer was reduced almost by 25%. And if you were on estrogen for an average of 5 years, estrogen replacement, and you ended up by some tragic event getting breast cancer, you were much better off. Your fatality incidence was decreased by 44%. Nothing has ever been so breast protective. And Leon Spiroff, who wrote, you studied Leon Spiroff's books. He's written all the gynecology textbooks for docs and gynecologists, for everybody. He started pumping out within a few years of people saying that estrogen caused breast cancer. He said, no, you're throwing the estrogen baby out with the bathwater. We've only seen protection. You're getting this all wrong. Naftalin from Yale was a major statistician who republished early on. That's why I wrote the book, Safe Hormones, Smart Women, because for some reason, people have been evaluating the Prempro arm, which was the progestins in that arm, as causing breast cancer. And this is what drives me absolutely crazy. A lot of times you'll hear there was just a study a week or two ago, and one came out in Sweden, and it was published in the British Medical Journal, and they said hormone replacement causes dementia. Well, but if you look, it's got synthetic progestins added to it, or it's horse estrogen, and it's oral and it's swallowed. So what a hormone is added to and how you take it into your body makes all the difference in the world. But somehow this message isn't getting out, and women are really missing out. And even triple negative breast cancer, where women aren't ER positive, PR positive, or HER2 positive, they should be able to be on hormones. For sure they should. They don't even have any hormonal receptors on their tumors. If you're a high-risk woman, you are denied hormones because they've stopped teaching hormonal menopausal medicine. And for gents, the same exact thing, andropausal medicine in med schools and in naturopathic schools and in osteopathic schools. So now when most average patients go to a regular doc and say, hey, doc, I'm getting kind of tired. I'm gaining a little mid-weight. I have a little bit more brain fog. I'm not the me I used to be. Do you think I should consider hormones? Most of the time they get a wrong answer because the doctors have been told that hormones drive cancer. So there's this huge misconception, and women miss out. And so I love having a chance to share this conversation with other women.
Yeah, it's such a powerful story that you mentioned your own story, and then the whole thing about the last 2 decades of the Women's Health Initiative. I'm curious if you have any insight into when that first came out in July of 2002.
It was July 2002.
About
July 9th was the fateful
July,
day.
The fateful day. If you have any insight about, was it just because that fateful day has been the start of 2 decades of misinformation, not only in patients, but more consequentially in physicians as well, to the point that, now to this day, they think it's such a strongly ingrained thing that estrogen drives breast cancer. I myself, only until I got out of residency, have started to understand hormones in a way that I was never taught before. So I'm curious about what you think that initial driver was. Was it just wrong analysis of data? Was it a type of maybe a political involvement in the results of that data? Do you have an insight into what started that whole thing with the Women's Health Initiative and publishing wrongly?
That is such a great question. I have thought about this question over and over and over again, because even the most well-intentioned physicians who are publishing data on, for example, there is an incredible, she used to be a breast cancer surgeon, and now she's a breast pathologist and deals with breast cancer, and she's championing testosterone in women. And I love her work, Dr. Rebecca Glasser. And I'm putting on a big Let's Talk Estrogen, Safe or Dangerous free evening on February 15th. And I had invited her. So we started chatting with each other. And it's going to be David Brownstein, David Rosensweet, Angela DeRosa, all of us seasoned working with with hormone patients for 30 to 50 years. And I invited Dr. Glasser to consider being on there. And she said, well, I don't really want to do that because I think estrogen drives breast cancer. That's why she's mainly using an aromatase inhibitor with testosterone. And even she feels that way. It is really ingrained in the American med school psyche. But yet in Europe, they did not go that route. With the Women's Health Initiative, was, usually medicine, the whole trajectory of medicine doesn't change with one small or two small studies. It usually takes a trend of studies and meta-analyses, which are large grouping together of similar studies to see the trend of a path of understanding how things are. In Europe, one, they didn't use synthetic versions. They didn't use Prempro. They used estradiol. And in Europe, they were surveyed, many gynecologists, and they said, well, just because there's this one small study, we're not going to stop using hormones. And in fact, there's now multiple countries in Europe that are socialized countries. Finland was the first country where they pay for everything. So they're very invested in patients staying healthier longer. And they've done research, and the women who take hormone replacement get less cancers, less heart disease, less dementia, and they cost the country less. So then all the rest of the Nordic countries joined in, and then Wales joined in, and then Greenland joined in. And then 2 years ago, Britain joined in a sliding scale. So many European countries offer for free hormones to women when they become menopausal because they stay so healthy, they cost the country less. At the very same time, overlapping with the United States, where we're teaching our physicians, like you learned that hormones drive cancer, when actually they protect. So I ask you, Mother Nature never does anything without a reason. So why would Mother Nature make the very hormones that drive humanity be pro-carcinogenic? It makes no sense. And if estrogen really drove breast cancer, we'd have more cancers when we're younger. They all say estrogen drives growth. Well, estrogen's the oldest hormone on the planet, and hormones speak to a receptor, which is like a satellite dish waiting for its signal, and then they signal genes, which is why genes hold all your archival ancestry information, and only hormones, as well as vitamin D, can signal genes. And so estrogen's the oldest hormone on the planet, according to Dr. Michael Baker, who was one of my consultants for my most recent book, Sexy Brain, on how pollutants are assaulting our hormones, and that's leading to gender bending and gender confusion. But so because estrogen's so old, she has many receptors. And each of these receptors, when they're signaled, have very different actions. So I worked at Tulane with the scientist who discovered these receptors. So Yanaki Gustafsson, who discovered the second receptor, estrogen receptor beta, he says this is our own natural chemotherapeutic agent in our body. It is our anti-proliferative agent. You want ER beta signals. It is anti-cancer, cancer protective signaling. So to just say that estrogen drives cancer is not appreciating the nuances and the multiplicity of receptors. It's a very guttural, it's actually it's like kindergarten hormone level of understanding. And the other thing is that there's two major cancer protective natural chemotherapeutic agents in the body. One, when estrogen signals ER beta, and the receptors are named by the alphabet. So alpha being the first receptor and beta being the second receptor. And as hormones are metabolized, if you can methylate well, the final metabolite of estrogen, 2-methoxyestradiol, is an incredible anti-cancer agent. So you want to know as a physician, how is my patient metabolizing their hormones, and are they making these natural cancer protective components of estrogen on their own? That's how you look at estrogen to know if it's balanced, and give estrogen to a patient in a way that signals all these receptors and makes sure that the cascade of metabolites keeps that patient safe. But to say that estrogen drives breast cancer, but I worked at Tulane also with John and Benita Kazanellenbogen, and the Kazanellenbogens, which is quite a mouthful of a last name, they along with Elwood Jensen, who discovered the first receptor, they all won the Lasker Awards because that's how breast cancer is profiled. It's all based on their work. ER positive, PR positive came from their work. So they say, yes, there's always been these two tracks of theories. One, that estrogen drives breast cancer, and two, that it has nothing to do with estrogen. Estrogen's protective, in fact, but it's cancer stem cells that drive cancer and recurrence of cancer. But they're scientists, they're not clinicians. So there's always been these two different theories. But in essence, there's now so much data, especially from the reanalysis of the Women's Health Initiative, that estrogens protect the breast. They don't drive cancer. And what's really drives me crazy is that right before July 2002, when in the United States, we pretty much stopped recommending estrogen for many women, especially if you're a high-risk woman, up till that time, there were 26 studies, Dr. Omar, where they gave breast cancer patients who were ER positive, right at the time of diagnosis, estrogen replacement so that they maintain quality of life while they're going through cancer treatment. And they had to have mild or moderate cancer. They couldn't have stage 3 and stage 4. And they were tracked with a comparison cohort. So they had a placebo arm. And in none of those 26 studies, one was run by MD Anderson, one was run by the University of Wisconsin, one tracked women for 30 years, one tracked women for 24 years. Avram Blooming ran a study tracking women with breast cancer, giving them estrogen for 26 years. Some of them were 4 or 5 years. So it was a compilation of studies. And in fact, I just sent that whole slide deck that I have because I lectured on that at the International College of Integrative Medicine a few years ago, saying there were 26 studies before estrogen got a bad name, where they gave estrogen replacement to ER positive breast cancer patients. They tracked them. None of them fared worse. In fact, in the majority of the studies, they fared better. And if they got a recurrence, they tended to have less death from that recurrence than a woman who wasn't on estrogen. And those studies have been forgotten. So I sent them to Dr. Glasser and I said, I'd love to chat with you about this, but please take a look at these studies. And Avram Blooming has written a book called Estrogen Matters. He talks about these studies and his own study, and that he feels, he's an oncologist from Southern California. In fact, he's the oncologist that before him and his group, if a woman was diagnosed with breast cancer, she'd have such invasive surgical intervention that most of her upper body and torso was hacked away. So early breast cancer intervention was horrific. It was almost like Frankenstein because they didn't just take conservative measures with surgery. And because of him, and it wasn't an easy path for him, he was able to shake the shoulders of orthodoxy and say a woman can get a lumpectomy and chemo and radiation, and she can live just as well as a woman who's getting all this invasive surgery. And he changed the course of surgical and treatment intervention for breast cancer patients. And now he's trying to do this with estrogen. So he wrote this book called Estrogen Matters. And I summarized a lot of this information in a little ebook on my website because so many women don't know this and so many doctors don't know this. And it's a shame. And the problem is, so you go back to your question, why did this happen? If this is the science, why is medicine going off on this different direction? And if you would have asked me this a few years ago, I would have said it was mostly misunderstanding and misinterpretation. But now there's been such clear research. In fact, the largest study ever run on hormones, it's still in peer review in a British Medical and Yale composite journal, but it's the 7 million Medicare study where they looked at our NIH and our National Library of Medicine looked at 7 million Medicare patients. So we have all their records, all the detail of their records. And they said, how many are on estrogen? 1.5 million women were on estrogen. So they looked to see how they got it into their body, their dosage, what they took, and then they looked at endpoints. They looked at 5 cancers, with breast being the most important one and for this discussion. And then they looked at longevity and heart issues and cognitive issues. And women on estrogen had statistically less of all 5 cancer: breast, uterine, ovarian, colorectal, and lung. Totally less. That's the largest study ever run. And the data now is enormous. So now after the pandemic, if you ask me this question, and I hate to say this answer, and I believe that a woman not on hormones, because we live longer, we live a third to a half of our lives in menopause, which is a new thing in humanity, although our life expectancy in the United States has gone down 3 years in the last few years. I believe that we are run by big pharma, and they want us to need bone meds and cognition meds and put us in the nursing homes. So we have this pharmaceutical industrial nursing home complex that is making money off of keeping us sick, because women on hormones are less sick and cost us less, such as the socialized countries in Europe have been seeing it. I never thought I would be what would be called a conspiracy theorist, but
Yeah.
how do you come up with any other answer of how people aren't? And women on hormones feel better, look better, act better, but they have less breast cancer. And if you divide up in a study, and progestins being the biggest issue, or swallowing it. So my one other question with all of this, that it's very hard not to get upset talking about it, actually, since I've been a patient over and over again. So the biggest form that women take hormones in is birth control. And what is birth control but synthetic progestins, which are the bugaboo, mixed with ethinyl estradiol. And when I was at Tulane, 2 controls were used to test if chemicals were endocrine disruptors. One was diethylstilbestrol, the drug my mother was given when she was pregnant with me. And the other one is ethinyl estradiol. So birth control pills are ethinyl estradiol and progestins. There's no debate. They increase your risk of breast cancer. The risk continues after you stop taking them. And no one's done studies. If you've been on them for 20 or 30 years, how long does that risk know? We know if you're on them for a few years, the risk of breast cancer is increased for 5 years. We know your risk of stroke, of migraines. We never condemn birth control pills. We hand them out like M&Ms, and 30 million women around the world are on them. So no one's complaining about birth control pills, which have the 2 forms of hormones, which we know are very dangerous. And yet we deny natural hormones to women as they're aging. This makes no sense. So you have to say what's behind this. What is behind this? Who's making money on this?
Yeah, because the science is very clear, and I'm on a goal now to, I am now seeing those women that are in their early 30s that have basically, ever since they were teenagers, been put on these birth control pills as almost a knee-jerk reflex from the gynecologist when they have some irregular cycles or heavy bleeding. And now they've been on it for 12, 16, 18 years, and I'm seeing them at this point. And so, trying to get off of synthetic hormones and using more bioidentical hormones has been a big goal of mine. I think as you spoke, I think what would be very interesting is also to see the rise of tamoxifen being the standard of care in absolute contraindication to everything that you've mentioned thus far. And so if we go to a oncologist, and I've had people within my family who have breast cancer, they've been put on tamoxifen. So I'm curious if you can speak to that a little bit about how that has become the standard of care, whereas that completely contradicts what we talked about as estrogen being protective in breast cancer. Well, and tamoxifen obviously being the anti-estrogen, for those who don't know.
They don't think that tamoxifen's mechanistic protection is due to it blocking estrogen, because in some women take tamoxifen and their estrogen elevates. And also tamoxifen is effective in triple negative with women who don't have receptors for estrogen. So there's a lot of thought that tamoxifen works by other mechanisms than blocking estrogen, because in, I think, like 30% of women, it elevates estrogen. It's said to be an estrogen blocker. But what's really worrisome is MD Anderson, which is considered the really iconic cancer center. In fact, I heard that they're tearing down the Irwin Center, the old Irwin Center here in Austin, and they're extending the Dell Med School, and they're adding on a whole other section of MD Anderson here in Austin. And MD Anderson has opened up a new place, a clinic called the MD Anderson Cancer Prevention Clinic, where if a woman is a high-risk woman, let's say she has lumpy, bumpy breasts, and she gets a biopsy and it comes back lobular hyperplasia, well, we know that woman has 12 times the increased risk of breast cancer. But if you and I were to recommend to her progesterone and iodine, we could probably reverse that and clean up her diet and look at a number of other factors. We could probably, in a very short period of time, get her out of those dangerous guesstimate statistics. But what they're doing for these women is they're putting them on tamoxifen for 5 years. They're treating people now as though they have cancer to avoid getting cancer. And that's becoming the standard of care. And that is really making me extremely nervous. I mean, we are constant, it's like the way we're pushing vaccines on pregnant women, you know, untested molecules, which is what happened to me. My mother had molecules that were untested put into her body, and then I couldn't have children. I had multiple cancers, and here I'm sitting having this conversation with you. It's very, very dismaying. And Craig Jordan, you know, before tamoxifen was put on the map by Craig Jordan, before then, metastatic breast cancer was treated with estrogen.
Yeah.
It was treated with high dose estrogen because hormones don't work like carcinogens. Carcinogen, the dose is the poison. So as you get a higher and higher dose, you risk more and more adverse DNA damage, which is the initiator of cancer. Right. But with hormones, as you get higher and higher, you turn off the system, you downregulate the system. Right. So they used to give high dose estrogen to treat breast cancer. And they only use 6 milligrams. Yeah. Move over Suzanne Summers. But so that's right. It's crazy. But the biggest, so this whole tamoxifen thing, I'm very, very worried that tamoxifen is going to start being recommended to many of our daughters, our young girls, if they just have lumpy, bumpy breasts, or if they just, you know, have irregular menses. And we are now seeing less and less normal hormone levels in younger and younger females and males because of plastics and many endocrine disruptors in our air, food, and water. And Harvard has been publishing, along together with the neuroendocrine unit of Mass General and psychiatric journals, they've been publishing, looking at young girls 13 to 24 who have irregular periods. So they should, you know, the regularity of your period translates a lot into how healthy you are. And it's hardwired. It's biologically hardwired. And when it starts to change, something's up. So if a woman's having irregular periods, they've started to do deeper dives. And a lot of times these young girls, especially athletes, because young girls now do a lot more athletics than they've ever done, they have osteopenia and they have anxiety, insomnia, body dysphoria, gender confusion, and the area of the brain that has a lot to do with higher executive functioning, which is ruled a lot by estrogen, is shrinking. So Harvard and the Neuroendocrine Institute has published a 1.5-year randomized trial where they were giving hormone replacement like you would to a 60-year-old woman to girls 13 to 24, because when they tested them, they had no estrogen, hardly any progesterone, a smattering of testosterone. So they just gave them hormones. And all in all, the group that were given hormones got rid of their anxiety, got rid of their insomnia, got their bone density normalized, and their brain, with functional MRIs, the volume of their brain normalized. So a lot of us are in a hormone mess because the planet is filled with all these hormone disrupting chemicals. My book, Hormone Deception, in the last third of it, shows how to decrease exposure in your home, where you get most of your exposure, in your supermarket cart, in your office. So I don't know why gynecologists aren't very intent on helping women who want to get pregnant learn how to decrease exposure, because you'll have healthier children and grandchildren if you can learn about all this. But they're not on the road. They're handing out birth control pills, and they're dissing hormone replacement. I know, it's very upsetting. If only our
system was like that.
And you know, no one wants to lose their license. Everyone's fearful of losing their license, so they want to color within the lines. And when I lectured in Chicago a few months ago to it was about 120 docs, there were 20 gynecologists in the room. And I mentioned the reanalysis of the Women's Health Initiative, and that the estrogen-only arm was never found to have caused any increased incidence of breast cancer. None of those gynecologists knew that information. None of them. When they came up and we chatted, we went to dinner, and they said, you know, we never hear anyone who knows all this data. We just learn what we learn, and then we go off and we do procedures and we work and we go home with our families. And there isn't any more deep dives into going beyond what they're told.
Yeah.
And of course, you get scared to go beyond what you're told because you've worked so hard. You don't want to lose your license, understandably. But we're in a
Yeah.
pickle. The American human being to stay healthy is in a pickle of who to go to. And so we're lucky that we have doctors like you who are trying now to think, be an agile thinker, and look at the science, really look at the science.
Yeah.
Now, it's very confusing because people can say, look at my science. No, look at my science.
Yeah, that's right. Yeah. And COVID has shown us that, where science can also become very tribal. So.
Oh, I like that statement. I like that.
Yeah. Yeah.
Science can become tribal. That's exactly right. Did you make that up? That's a really good statement.
Yeah, actually. Yeah.
That's great. I like that.
Yeah. So, yeah. And this is why these conversations are so important is we really need to, I've been woken up to this reality. I think a lot of other patients and clinicians need to be woken up to the way that you were taught in med school is not what the science tells us and is not, or should not be the standard of care. And so I'm glad that we're having this conversation. I wanted to maybe lastly ask
women
you,
are scared to death of hormones. They are really, they rather get fractures, dementia, overweight, high blood sugar than be on hormones. And they don't understand that it's actually the opposite. So it's wonderful that you're having this conversation. Thank you.
Yeah. And women as patients are, and I would say to some degree, physicians like myself can also be scared of them because of what we hear. And then we worry about what that means for our practice and our license when you do something that goes against the grain. So you're absolutely right that there is that unwarranted fear of hormones. I wanted to ask you about switching gears a little bit into using estrogen as effective replacement. If you had a preference into in terms of dosing, method of taking it, and if you could just speak to that a little bit.
Well,
for menopausal women.
So I lecture a lot for A4M, and there's two relicensing groups for becoming a functional doc. There's IFM and A4M and then things like that. But they're very, very conservative, and they start at the lowest dose and go to the smallest dose that just gets rid of your symptoms. But I don't really agree with that at all, because what you really want to do is where you really slow down aging is by maintaining the volume of your hippocampus. Your hippocampus is where you live. It's where your memories live, your orientation, your motivation, and it shrinks after the age of 40, 1% a year, normally if you don't have hormones on board, because you don't have hormones on board, because the hippocampus makes hippocampal estradiol in response to a woman having estrogen in her bloodstream and to a man having testosterone in his bloodstream, because the hippocampus has a lot of aromatase enzymes which convert that testosterone to hippocampal estradiol. The larger your hippocampus, the more you feel like your old, better self. Although I was older before my time, so it's not me, but most people say when they get older, I don't feel like my younger version of myself. And a lot of that has to do with your hippocampus. And there have been studies done where they've looked at the dosing of estrogen to figure out what doses really maintain a healthy hippocampal volume. And the great thing with the hippocampus is it's like the liver. There's not a lot of organs in the body that can regenerate. If you have a whole bunch of kidney stones and you have a lot of lithotripsy, you lose a lot of renal mass. You don't grow more renal mass. I worked for 10 years in a dialysis center here with Dr. Moncrief, and we co-invented a dialysis drug together. And that was a whole nother part of my life. But there were a number of our patients, they had multiple injuries to their kidney, and you can't reboot your kidney to a certain degree. But your liver can be rebooted, and your hippocampus can be rebooted. If it shrinks up from being an older age, it can revolumize as long as it hasn't gotten where it's like a raisin in pathological Alzheimer condition, and it's gone beyond where it can respond. And so you want enough hormone on board where silently you're maintaining the volume of your hippocampus and the integrity of your bone and many, many other places. Hormones aren't just about sexy and reproductive things. Like your lungs are completely lined with receptors for progesterone. Progesterone has a lot to do with lung repair. So Mount
Right.
Sinai did a study with COVID patients, male COVID patients in the ICU, and they gave them 100 milligrams IM BID twice a day of progesterone and tracked them with men who were getting standard of care. And the men that were given progesterone plus standard of care left the hospital in shorter days there with less complication because they were able to know that progesterone helps heal the lungs. So we're more prone to pneumonia as we age because we don't have more progesterone. So we give men progesterone. We don't give just women progesterone, especially with congestive heart failure, etc. So to give hormone dosing to the point where you're getting these silent but internal things that have a lot to do with your keeping you the way you used to be, really resilient and strong. So the typical dose of estrogen is somewhere between 0.6 milligrams to somewhere like 2.6, 2.8 milligrams of estradiol equivalents. And you have to add in estriol with that. But they're outliers. There's some people who can't handle that at all, and they need less. And there's some people who need more. David Rosensweet tells the story of a gynecologist he met who had sat with her mother in the dementia unit. I lived with my mother in the lockdown dementia unit all through her dementia journey. But her mother had dementia and she was still seeing patients. She was in her mid-60s and she started to lose words and feel like she was. And she was on hormone replacement. So she kept upping it till she felt like her brain turned on. In other words, her hippocampus enlarged. She did it to the point where she started menstruating again. And if she kept herself menstruating again, she kept her cognition bright and she could keep seeing patients. So she shared with him that she was on 8 milligrams, which normally in most women would downregulate the system, but on her it didn't. So we have typical dose ranges and then we have outliers.
Right. And was that oral estradiol that he was giving?
No. We never give estrogen orally because then it goes through the digestive tract and the liver, and the metabolites that it makes can be pro-coagulative and inflammatory. And that's why in the studies where they say that estrogen causes stroke, it's because it was swallowed. Or they say that estrogen causes dementia, it's because it was given with progesterone or it was swallowed. So you have to look at the caveat of the details of the studies. So the safest way to take in hormones, although every woman is different, and throughout your life, you might, if you're on hormones for decades, you might need it one way in a few years here and another way a few years here. But sometimes you can take a hormone topically and you can take it vaginally. But we usually don't like taking hormones orally except for progesterone. Progesterone is a very safe one, and you want it to go through that first hepatic pass because then it makes neurosteroids, which are very brain protective. In a young person, progesterone is produced as well as estrogen in 6 different areas of the brain to protect the brain. Hormones are extremely brain protective. Many of my colleagues feel that if hormone replacement was pushed, educated to doctors, and encouraged in patients, that 85% of our people with dementia would not have it. We'd have less Parkinson's, less Lewy body disease, less Alzheimer's. And, most of my friends can't even talk like I can talk, or because I felt comfortable with pushing for a long time because of having breast cancer. I did that smallest dose for the smallest amount. And then after the reanalysis, I went whole hog and my brain went so turned back on. And I have noticed such a difference in my 75-year-old brain with my girlfriend's 75-year-old brains. It's huge. But of course, I work out every day and eat really well and do a lot of other things most of the time. But it's very aggravating how many people have Alzheimer's disease that wouldn't have it if they were allowed hormone replacement.
Or osteoporotic fractures or cardiovascular disease. So many other things. So this has been such a great discussion, and I'm wondering if you have any last words you want to leave the audience with as takeaways.
Well, and I'm munching on a little mint here, sorry. Because I worked with Elwood Jensen and Yanaki Gustafsson, and they were the dudes, they said, a hormone isn't just about its levels. So don't debate so much whether saliva versus blood versus urine testing is right. If a hormone can't get to its receptor.
Yeah.
And so zinc pulls the hormone in, it parks like a car parking in a parking space. So the receptor has to be available, and the receptor is like a bowl for nutrients. What you eat and digest and how you successfully do that puts vitamin A, iodine, magnesium, zinc, B6, etc. Your receptors hold all these nutrients. That complex allows a hormone to optimally signal. So they would constantly talk at Tulane. We would put on these conferences called hormone conferences. There were 33 years of them. The first 27 years were called Estrogen in the Environment conferences, and the last few years were called hormone. The last few years sounded like you were at a naturopathic convention because they were talking about how you need to have nutrients in the receptor needs to be available. You can't have too much cortisol or stress because the cortisol can block it, as well as endocrine disruptors. But the whole point was receptor functionality. You need functional hormone receptors. Even if you're not on hormone replacement, but you're an 11-year-old girl and you're starting to go for puberty now, you need receptors that work well. So it was all about receptor functionality. So I had designed Metagenics' first femline. I love to cook. So I ended up loving formulating nutraceuticals because it's kind of like cooking.
Yeah.
So I designed Metagenics' first female line for physicians, which went extremely well. And I learned a lot by doing that. So I decided, based on the work of Elwood Jensen and Yanaki Gustafsson, to come out with products that cleared off the receptors and made them more functional. So Biotic Scientific Research is now coupled together with me, and we have a product called Receptor Detox and another one called Hormone Balance and Protect. And because women are worried about cancer, and because I've had cancer, so I always worry about making my remission my mission. I wanted to put botanicals in there that tamp down cancer stem cells that drive cancer, and that also signal what Yanaki says are our own endogenous chemotherapeutics that signal the second estrogen receptor, ER beta. So I've created these two new products, and I would love to have you, I don't know if you've ever heard of them, Receptor Detox and Hormone Balance and Protect.
I have. I haven't used them, but I've heard of them in a talk of yours. So I definitely look forward to certainly using them in my patients.
Okay, well, so that's my closing work. And people can go to my website, drlindseyberkson.com, DrLindseyBerkson. And I write every single morning in something called Agile Thinking Substacks, and they might want to sign up for that. If you go to the bottom of my first page, it tells you exactly what levels. I have 3 different levels. So at one level, it's physicians, and then the middle level is somebody who wants to jump in every month and ask anything you want to ask and have a lot of conversations. And the lower level is a Facebook group along with writing and Substacks. But also, if you want to go to this Let's Talk Estrogen and hear Dr. Brownstein, who's one of the world's expert in hormones, and Dr. David Rosensweet, who happened to be my cancer doctor 30 years ago and now is a hormone expert. And how crazy is that? And then Angela DeRosa, who is phenomenal, and she talks about helping to train doctors to know that you're getting the right bang for your prescriptive buck if you track FSH in your patients. So she's going to chat a little bit about that. So we're giving a free evening, February 15th at 7 p.m. And you can go to my link, or I'll send you the link and you can send it out to your listeners. And it's for free, and it's going to be an hour and a half. And we're recommending that you invite your physicians to come, especially your physicians that don't know any of this about hormones, and that we're going to have the last half hour be Q&A with practitioners.
Okay. Is that a virtual program or is that in person?
It's going to be online. It's going to be online. Okay. So we hope to have a lot of people there because we hope to dispel all this misinformation about estrogen. And if you want to know about estrogen, I have a book called Safe Hormones, Smart Women. Hormone Deception is a pivotal book on explaining endocrine disruption because you want to protect your babies and grandbabies. And my last book was called Sexy Brain. I have 21 books out, and I have 2 more books that I'm working on presently. And maybe God will continue to give me some energy to finish them because now I want to go out kayaking on Lady Bird Lake more than right.
Yeah, that's fantastic. Well, this has been such an insightful conversation. I really appreciate your time and your expertise on this. And I look forward to hopefully continuing this conversation and maybe doing something further as well.
Okay, well, I so appreciate that you reached out to me, and I love that we're in the same city. We should do dinner sometime. Let's do
Absolutely.
dinner sometime.
Absolutely.
And if you're
Well,
married, bring
thank you
your
so
wife,
much.
Okay.
Sounds great. Well,
Okay.
good speaking to you, and I'll talk to you soon. Thanks for
Okay,
joining.
blessings. May the hormonal force be with us all. Bye-bye.